Well, hey guys, in this edition of Why You're Breaking Out, we're going to be going over skin breakouts that look like acne but are not acne. I want to highlight these conditions for you because many times you may be struggling with your skin assuming you're breaking out. You're getting pimples and you might assume that that's acne. Logically, you may reach for an over-the-counter acne treatment like salicylic acid, adapalene, benzoyl peroxide, only to find these don't work, or in some cases, unfortunately, they might actually make things worse for you. In fact, I get DMs, comments, messages all the time, something to the effect of, hey, I've been on adapalene for 9 months now, and I am still purging. Now, purging, which refers to a temporary increase in the number of acne spots when starting certain acne treatments, this process should only last a couple of weeks. Now, in my video on purging, I highlight that one reason someone's skin may continue to worsen with, say, different gel or other acne treatments is that they don't actually have acne. So if you're breaking out with pimples, what might it be besides acne? Acne-like eruptions can occur as a result of a ton of different stuff: infections, hormonal abnormalities, contact dermatitis, a side effect of a medication. In dermatology, we refer to these as acneform eruptions. Basically, they're skin conditions that look like acne. They consist of red bumps, pus-filled bumps, which you might refer to commonly as pimples, and in some cases they're going to be cysts, they're going to be nodules. However, in contrast to true acne, acneform eruptions typically lack comedones, aka blackheads and whiteheads. And oftentimes with acneform eruptions, the physical location may be outside where acne typically occurs. Now, another clue in the history in some acneform eruptions is that the pimples, the spots, the bumps, they erupt all of a sudden, and on physical exam, they pretty much all appear the same. They are what we call monomorphic. Sometimes these conditions are really easy and straightforward to diagnose. You just walk into the room and you know exactly what it is just by looking at the patient and talking with them for a bit. Now, in other cases, some additional tests may be needed, like blood work, skin biopsy. A lot of times we might need to take a swab of the pus and send it to the lab to see if any particular bacteria or yeast or fungus grows out. What are some acneform eruptions? Number one is eruptive vellus hair cysts. Now, these are basically little tiny cysts that are filled with a peach fuzz hair and some dead skin cell debris. And they can look like discrete little bumps. They can be yellowish, bluish gray, slightly brown, even slightly red. They most often happen on the chest, the arms, and the legs. Rarely though, they can also happen on the face, especially like around the eyes and the eyelid area. And oftentimes they have a little dent in the center that looks like a belly button. We call that umbilicated. These are not life-threatening, and in contrast to acne, they don't heal with a scar. 25% of cases of eruptive vellus hair cysts, the bumps will spontaneously go away on their own as the skin turns over naturally and the natural exfoliation processes will extrude them. Mechanical exfoliation can actually be helpful for stubborn cases of eruptive vellus hair cysts. Believe it or not, this is where you could make a case for everyone's favorite skincare villains, St. Ives apricot scrub and or the Buff Puff may be helpful here. Alternatively, there's 10% urea, there's 12% lactic acid, like an amlactin. This can help the bumps go away faster. And of course, what can retinoids not do? Tretinoin, tazarotene, and adapalene are all options for helping these to go away faster. Check out my video on eruptive vellus hair cysts. I go into more details. Number two, steroid acne. Corticosteroids are a class of medications that are used throughout medicine to treat many diseases. They work by suppressing the immune system. They're anti-inflammatory. The development of acne as a result of these medications is well established. So with steroid acne, typically you have an eruption of monomorphic, again, all the same size, appearance, pink little pimples. They usually affect the trunk, like the chest and the back and the shoulders, also the face. Corticosteroids, they're a class of medications, and they can be delivered to the body in a variety of ways, and you can develop steroid acne from any of these delivery routes, including taking them by mouth, getting them through an IV, inhaling them, as is the case for people who have asthma, or applying them to your skin. When it comes to either topical steroids that you put on your skin or inhaled, the acneiform eruption will often be localized applies just to the area where you're applying it, or in the case of inhaled steroids, around the nose and around the mouth. You can buy 1% hydrocortisone over the counter, and I always caution you guys, unless you have been told explicitly by your healthcare provider to use this on the face, don't use it on the face because there can be a lot of side effects, and steroid acne is one of them. Now, onset of steroid acne can vary from immediately following starting the drug, or it can actually take several months after you've been on the drug for it to appear. Now, steroid acne typically resolves upon discontinuation of the steroid with no additional treatment really needed, although in some cases, acne treatments can be beneficial. Number 3, bacterial folliculitis. Now, folliculitis is just a medical term for a bunch of different conditions that entail inflammation around the follicle. It can be inflamed because of an infection. In the case of bacterial folliculitis, it's one of the most common types of folliculitis. It's generally, in most cases, caused by a bacteria called Staphylococcus aureus. Now, some people are predisposed to getting this because their nose is actually colonized with this bacteria. And then you have factors like occlusion that can trap the bacteria up against the skin, like wearing really tight clothing, living in a humid environment. These are risk factors. Anything that causes a lot of friction can introduce that bacteria down into the follicle. Bacterial folliculitis is typically what's called superficial, meaning the inflammation is at the top part of the hair follicle. It's called impetigo of Bockhart. And you get red bumps filled with pus, basically pimples, and those pimples eventually crust over. However, the inflammation can go deeper down in the follicle, and when the full length of the follicle is involved, you actually get boils, which can be very painful. Folliculitis can be very itchy as well. So this is a condition where a skin culture, a swab of the pus, is usually necessary. Check out my video on painful body pimples if this sounds like something you're dealing with, because I give a lot of tips in that video for hygiene and for how to prevent these from coming back and how they're treated. Speaking of bacterial folliculitis, we need to talk about a different bacterial infection of the follicle that can look like acne. It's called gram-negative folliculitis. Now, this is a condition that arises when someone has been on antibiotics too long, and the antibiotics have messed up their skin microflora, their skin microbiome. This is something acne patients may encounter. It's not staph bacteria, but rather bacteria that are characterized by being gram-negative. Now, you can get pus bumps, or you can even get deep cystic lesions with this eruption. Often it's around the nose, potentially extending to the cheeks and chin. While it doesn't appear to be that common, it's likely underreported. It's definitely something to consider in someone whose acne continues to get worse despite 3 to 6 months of antibiotics. Once it's confirmed, the preferred treatment is actually a course of isotretinoin, which is Accutane that knocks down sebum production and creates an unfavorable environment for those gram-negative bacteria. Number 5, another folliculitis, this time not from bacteria, but rather yeast, Malassezia yeast to be exact. Now, the internet calls this condition fungal acne, but it is not acne, and the proper terminology is either Periorificial folliculitis or Malassezia folliculitis. Unlike acne, no comedones. The eruption is, again, monomorphic bumps, often very itchy, usually on the chest, but sometimes the forehead, the sides of the face. Now, this yeast is part of our normal microflora, but in certain situations, the immune system reacts to those little yeast, or they can just get too comfortable, and then they can cause skin problems, including seborrheic dermatitis, tinea versicolor, and of course, germane to today's video, Periorificial folliculitis. Now, this yeast thrives in a moist, humid environment, and it also feeds off of your oil, your sebum. So we commonly see this condition in patients who are immunosuppressed or have been on prolonged courses of oral antibiotics that disrupt the skin's microflora. Periorificial folliculitis can also happen with corticosteroids, and it may actually overlap to a certain extent with steroid acne. Now, young teens are making a lot more sebum as their hormones change, and if they live in a humid climate, that can also favor Malassezia folliculitis, and it's something that you have to consider. It doesn't respond to and can even be aggravated by a lot of typical acne treatments. Topical or oral antifungals are used to treat this, though recurrences are possible. Some patients require a course of isotretinoin, aka Accutane, to help Cut down on sebum. Again, the yeast thrives on your oils. That's what it feeds on. So isotretinoin can help. Check out my video all about fungal acne. I go into more details on the different types of treatments and skincare recommendations in that video. Number 6, rosacea. Rosacea is a chronic, relapsing, prevalent inflammatory condition involving the convex surfaces of the central face. Now, you get these acne-like pimples, but again, no comedones. And in contrast to acne, rosacea is not a condition where you have excessive oil production, aka seborrhea. Instead, you have facial redness, and you have dilated blood vessels, which are called telangiectasias. Patients experience episodes of flushing and blushing triggered by heat, spicy foods, sun, irritating cosmetics, changes in hormones. They also experience symptoms of stinging, burning, facial swelling, redness. And in contrast to acne, rosacea can involve your eyes as well. Patients with rosacea, they're very sensitive to things that come in contact with the skin, and a lot of acne treatments are really way too irritating for rosacea. In addition to avoiding triggers, treatments include topical ivermectin, aka cilantro, metronidazole, azelaic acid, oral antibiotics, and vascular lasers to target the redness. Check out my videos on rosacea to learn more about the different rosacea treatments. Now, number 7 is actually very closely related to rosacea. It is the dreaded perioral dermatitis, or more accurately called periorificial dermatitis. Bumps and redness that, in contrast to rosacea, not located on the convex surfaces of the face, but rather around the mouth, around the nose, and or around the eyes. The orifices can be triggered by hormones, irritating skincare products, heat, wind, harsh toothpaste, and topical steroids. May also overlap to a certain extent with steroid acne. This is a really debilitating condition, and it can take a while to clear up. Treatment actually includes what's called zero therapy, meaning you completely withdraw any suspicious topical triggers. And if necessary, topical treatments like metronidazole, azelaic acid, erythromycin, pimecrolimus can be very helpful. Or in some cases, a course of oral antibiotics can likewise be beneficial for more severe cases. And then last but not least, Demodicosis are these little mites that everyone has on their skin. They dwell in close proximity to the hair follicle. Our skin is colonized with these mites. Doesn't normally cause any problem or any symptoms, but if the mites get too comfortable, it can cause problems in the formation of little bumps, often like around the brow area and the cheeks. Now, there's some overlap here with rosacea. If you take a skin biopsy of somebody's rosacea, you will see an increased burden of these Demodicosis mites. But they can lead to facial eruptions that imitate acne and presents with localized, non-scaly, little pus bumps around the follicle. An excessive population of Demodicosis can be seen in people who are immunodeficient, who have diabetes, obesity, end-stage renal disease, or just poor hygiene in general. Demodicosis is actually not uncommon in older adults, probably related to decline in immune function that happens with age, as well as an abnormal skin barrier that comes about with age. You subsequently have reduced skin hydration. Now, treatment for demodicosis includes topical ivermectin, aka cilantro, metronidazole. Some cases respond well to light therapy, namely intense pulse light. All right, y'all, so that is a roundup of just a few, not all, conditions that look like acne but are not acne. I really hope this video was useful. If you liked it, give it a thumbs up, share it with your friends, and as always, don't forget, sunscreen and subscribe. I'll talk to you guys tomorrow. Bye.